Hi, my name is Bert Abrams, and I've prepared this YouTube video about the connection of gout and sleep apnea. It started with my own experience years ago when I noticed the connection in myself, and almost no physician that I asked to explain it to me could do that. So I started doing my own research. There was one physician who hypothesized the connection, and he was partly right. But there's more to it than what he had told me. So this post is based on what I have learned from my education and also what I have deduced from what I've learned. I've tried to prepare it so that it can be read by medical practitioners who want to learn and by gout patients who want relief and survival. It runs almost an hour for those of you who may not have that much time to spend in one sitting. It's broken into chapters, so you can choose which chapters you'd like to read at first, and then perhaps come back to read others later on. So let me start with me. In 2003, I trained myself to sleep exclusively in a lateral position, and ever since then, my increasingly frequent arthritic gout flares ceased immediately and completely. How does this statement strike you? With bewilderment? Disbelief? Stay tuned. First, some background information. This is the definition of sleep apnea in adults. It's the frequent cessation or significant reduction of breathing during sleep for at least 10 seconds at a time, averaging at least 5 such events per hour during the sleep period. There are two major subcategories. One is obstructive sleep apnea, which is due to the repeated closing of the airway in a transient way. It's readily treatable, and it's very common in adults. The second category is central sleep apnea, which is due to the repeated transient lapse of the brain's breathing control. There is no closure of the airway. Now this is less treatable, and it's much less common. Most of the literature in medical journals is related to obstructive sleep apnea, so that's what I'll be talking about most. There's one other thing I want to point out to you on this slide. Below the horizontal line at the bottom are the surnames of two individuals, followed by a medical journal name, in this case JAMA, Journal of the American Medical Association, and the year 2020. These two individuals are authors of an article appearing in JAMA in 2020 that's related to the information on this slide. It's enough information in the reference for you to be able to find it easily, and I didn't want to take up a lot of space on references in the slides. I'll just use this abbreviated form in almost all cases. So here are some of the immediate effects of sleep apnea. There are frequent periods of suffocating oneself every night. That results in intermittent reduction of oxygen in the blood, often referred to as chronic intermittent hypoxemia, plus hypercapnia, which is an imbalance of carbon dioxide over oxygen in the blood. There are stress hormones generated, catecholamines and cortisol. And of course, there's interrupted sleep. Plus, in the obstructive form of sleep apnea, there's intermittent negative intrathoracic pressure. That's because the diaphragm is trying to expand the lungs to take in more air, but the airway's closed, so there's no air coming in, and the result is negative pressure in the thorax. Here are some of the salient features of obstructive sleep apnea. It's very common, very serious long-term consequences when untreated, but it's readily treatable. Unfortunately, it's grossly underdiagnosed, and it's generally exacerbated by a supine sleep position. That is, sleeping on your back makes it worse. Now, here's my definition of gout. It's based, most of the medical information I've read about gout seems to be inconsistent in the way they defined what gout is. So I had to make up my own definition based on two references. One is a book by Turkle, Taub, and Edwards called Gout, and the other is a medical journal article by Bursill and others speaking on behalf of the organization called GCAN. GCAN is an organization of medical professionals that is focused on new information and education about gout and other crystal deposition diseases. So, gout is a deposition of crystals of monosodium urate, often referred to as MSU, in body tissues and fluids, resulting from a supersaturated concentration of serum uric acid, also called hyperuricemia, with at least one of the following symptoms: acute or chronic arthritic pain and inflammation, that is, pain in a joint, that's often referred to as a gout flare or a gout attack. Or there can be tophi, which are packets of monosodium urate. The tophi can be subcutaneous, that is just below the skin, where they're visible and palpable, or they can be internal, where they're neither visible nor palpable. And the final symptom is called uric acid kidney stones. Most kidney stones are calcium-based. About 10% of them are based on the monosodium urate crystals, and they're called uric acid kidney stones. Here are some comments about uric acid in the human body. The cells, uric acid is a waste product from every cell's metabolic processes. The cells dump their uric acid into the bloodstream as a conduit to carry it away for disposal. Other uric acid in the blood results from eating or drinking items that are high in purines, which are chemical compounds that are chemically related to uric acid, or by the liver processing the fructose content of sugars. Most serum uric acid is disposed of by the kidneys for excretion in the urine. Some serum uric acid is decomposed by intestinal bacteria and excreted in the stool. The supersaturated concentration of serum uric acid, also called hyperuricemia, can be continuous or intermittent. It leads to the precipitation of MSU crystals, and that is a necessary condition and a precursor for gout to occur. So, how sleep apnea causes monosodium urate precipitation and gout in those who are genetically predisposed to develop gout. There are three things that I've learned about from reading medical journal literature. First is there's an increased influx of uric acid into the blood. That's intermittent. It's based on the hypoxemic episodes of sleep apnea, which induce cell catabolism in all oxygen-starved cells in the body. in which adenosine triphosphate undergoes a chain of chemical transitions, often referred to as nucleotide turnover, culminating irreversibly in the generation of excess uric acid fed into the blood. The fact that the formation of uric acid is irreversible means that in those periods during sleep when normal breathing is returned, the uric acid does not go back up the chain. It remains as uric acid, ready to be disposed of in the bloodstream. The second reason is that the hypoxemic uric acids reduce the solubility of uric acid in the blood. This is intermittent also. The hypoxemic episodes lead to concurrent hypercapnia, remember, excess of carbon dioxide over oxygen, which leads to acidosis. That is, the blood is more acidic, and it can hold in solution less of other acids, including serum uric acid, which is less soluble, more likely to precipitate. The third effect is a long-term effect, and it decreases the flow of uric acid from the blood into the kidneys. The chronic intermittent hypoxemia gradually reduces the kidney's glomerular filtration rate, which slows removal of uric acid from the blood. Now, all three of these reasons for sleep apnea causing gout are present in the medical journal literature in disparate locations. They're not all put together. It was up to me to realize when putting these together, these are perfect storm conditions for MSU to precipitate. And that's why gout flares typically originate during sleep. Furthermore, once sleep apnea is resolved, the first two conditions, the intermittent conditions, don't occur at all, and the third condition, the long-term effect on the kidneys, gradually reverses after about 3 months of no sleep apnea. For those of you who may have had difficulty following all the words I had on the previous slide, here's a pictorial analogy of what's going on that show how gout results from sleep apnea. In this slide, I'm viewing the blood as a container, a storage container for uric acid, as it transports it from where it's generated in the cells to where it's disposed of in the kidneys. So from the cells, the pipeline into this container is increased because during the hypoxemic episodes, there's increased cell catabolism, leading to excess generation of uric acid. There's also decreased outflow of uric acid into the kidneys because of the reduced glomerular filtration rate. Furthermore, the size of the container is reduced during the hypoxemic episodes because of the serum acidosis. So, when the container reaches full capacity, out pops the cork, and the crystals of monosodium urate precipitate. These crystals, in order to form, take a lot of serum uric acid, take a lot of uric acid from the blood, and they are the crystals which cause a gout flare in those who are genetically predisposed to gout when these crystals form inside a joint. One of the things in Turkeltaub and Edwards' book, which I think is very wise advice, is they say clinicians should always consider what the cause of hyperuricemia is in the individual patient. Sleep apnea is one cause that should never be ignored. Now here's a block diagram that I made up showing how obstructive sleep apnea leads to a gout flare with all the intervening steps plus the other contributing factors. The intervening steps, of course, are direct result of the chronic intermittent hypoxemia, which produces excess uric acid, the increased acidity or reduced pH in the blood. And there's one other episodic effect, which I did not yet mention, and that is the chronic intermittent hypoxia leads to lactate in the blood, which leads to urate1 reduced, which reduces the reabsorption of uric acid by the kidneys, it producing more hyperuricemia. Then, of course, there's the long-term gradual reduction in glomerular filtration rate, leading to hyperuricemia. Plus, there are other contributing factors like diuretic medication, imbibing alcohol, fructose digestion, and digestion of animal purines. These are all factors which lead to hyperuricemia, but the tipping point is reached when obstructive sleep apnea leads to chronic intermittent hypoxemia. When the hyperuricemia can no longer be dissolved in the blood, it precipitates as new, that is nascent, crystals of monosodium urate. Sometimes these crystals form in synovium, that is joint fluid. And when they do, in those people who are predisposed to gout, the immune system undergoes a number of developments in leading to a gout flare, the pain and inflammation of gout in a joint. This occurs only in those people who are genetically predisposed to getting gout. Now, there's one other contributing factor here, and that is urate-lowering therapy. These are the pharmaceutical products which are often used to treat gout, which suppress the generation of uric acid. Nevertheless, in some cases, the obstructive sleep apnea is severe enough to overcome the suppression of urate-lowering therapy, and a gout flare will develop overnight in those types of situations. Now, this chart I showed to two gout experts that I am in relatively frequent email correspondence with. I wanted to get their take on it. One of them replied to me, "I love it." And the other one replied, "It's 100% correct." So I feel confident in showing it to all of you. Now, here are some comments about the measurement of serum uric acid. First, when I first consulted a rheumatologist about my gout, that was over 30 years ago, in the early stages of my gout, he extracted some fluid from the affected joint, viewed the fluid under his polarizing microscope, and declared classic gout. I told him that my primary care physician had arranged for me to have my blood tested 2 times to measure the level of serum uric acid. And both times, my primary care physician told me that the readings were within the normal range. The rheumatologist told me, "Oh, we don't pay any attention to that. That's too variable." Now, at that time, that was before the treat-to-target therapy had been adopted by rheumatologists, which is based on the measurement of uric acid in the blood. And still, it's variable. And what happens during sleep for people with sleep apnea could be a large reason why it's so variable. Because the serum uric acid is always measured during waking hours when it's convenient. And when that happens, the peak value that resulted from sleep apnea dissipates. It diminishes because the transient hyperuricemia from sleep apnea dissipates after waking and normal breathing has restarted. Furthermore, if monosodium urate has precipitated during sleep, then the belated measurement misses the peak value by a large amount because the formation of those crystals takes a lot of uric acid out of the bloodstream. In general, the conditions for measurement of serum uric acid need to be standardized to minimize its measurement variability, similar to the standardization of conditions for the measurement of blood sugar, glycemia. People whose blood sugar should be measured usually are told to fast for 12 hours beforehand with nothing but water. And then the measurement is taken. That's one set of conditions. Another set of conditions could be what's called a glucose tolerance test, where the patient is told to swallow some glucose, and then at prescribed intervals afterwards, the blood is taken to measure the level of blood sugar. But for the measurement of serum uric acid, despite the known variability, there is no set of standardized conditions to minimize its measurement variability. Now we're coming near the midpoint, and I have some questions that I want to pose to you and see how well you can answer them based on material that I have told you and some reasoning skills, and then I'll tell you my answers to. So the first question is, why does gout flare more frequently in spring and early summer than in other seasons? It does? Yes, it does. That's been found by Naomi Schlesinger and her colleagues in several different geographical areas of the United States. It's been found by Massimo Gallerani and his colleagues in Italy, and by Dr. Choi and his colleagues in Korea. It does. Second question, why is there increased risk of recurrent arthritic gout flares with hospitalization? And that's been found to be the case by Maureen DeBrea and her colleagues at the Boston University Medical Center. Why? Third question, why is gout not present in almost all individuals with sleep apnea? I've already told you the answer to that. That should be pretty easy for you to answer. Fourth question, why does resolution of sleep apnea not result in reduced serum uric acid? And there have been a few papers that measured serum uric acid after sleep apnea has been resolved for a month or several months, even up to 14 months afterwards. And the serum uric acid did not reduce much at all during that period. Why not? Fifth, how early in the multi-year development of sleep apnea would gout be anticipated to begin? Now, here are my answers. Gout flares more frequently in spring and early summer because seasonal allergies inflame the airway linings, narrowing the airway and making it more likely to close up during sleep. Second question, why is there increased risk of recurrent gout flares with hospitalization? Because almost all hospital patients are hooked up to an IV and or to monitors, so they sleep supinely to avoid disturbing the hookups. That is, they sleep on their backs, the worst sleeping position for sleep apnea. Third question, why is gout not present in almost all individuals with sleep apnea? In fact, the prevalence of gout is estimated to be about 1/6 the prevalence of sleep apnea. And as I told you before, MSU precipitates in almost all individuals with sleep apnea, but only those genetically so predisposed will develop gout. Fourth question, why does resolution of sleep apnea not result in reduced serum uric acid? Because there are lots of monosodium urate deposits throughout the body from the long term of sleep apnea before it's finally been resolved. These deposits dissolve so slowly over years, and until they do, the serum uric acid level remains in equilibrium with the dissolution of monosodium urate. That is, every incremental reduction in serum uric acid level results in more dissolution of monosodium urate, which replenishes the serum uric acid in the bloodstream. Fifth, how early in the multi-year development of sleep apnea would gout be anticipated to begin? As early as overnight hypoxemia leads to synovial MSU precipitation, that is precipitation of monosodium urate in joint fluid. Now, here are some studies that are needed relating gout to sleep apnea. The first is a clinical determination of sleep apnea's prevalence in the gout population. Just how many are we talking about? Now, there's been one study that approaches this, but not exactly what's needed. This study was done by rheumatologists in Spain who found that 48 of their 54 gout patients in that cohort had sleep apnea. That's 89%, 8-to-1 odds that if they had gout, they had sleep apnea. Unfortunately, the cohort selection was biased because the people in that cohort were selected based on sleep apnea questioning as a pre-screening method for including them in that selection. What's needed is a study using randomly selected gout patients with no pre-screening. The second study needed is a clinical determination of the degree of gout mitigation by overcoming sleep apnea as compared with the degree of gout mitigation by urate-lowering therapy pharmaceuticals, which are commonly used as treatment for gout. The third study is a determination of the reduction of risk for cardiovascular events, hypertension, kidney disease, diabetes, cancer, and mortality by overcoming sleep apnea when gout first manifests, as compared with what I think is a questionable benefit of urate-lowering pharmaceuticals for all these diseases. In fact, the reason I listed these diseases is they have all been mentioned as comorbidities of gout. They are also known consequences of sleep apnea. And it is known that if sleep apnea is resolved early enough, the risk for developing any of these diseases is greatly diminished. Now, I've been talking with a rheumatology researcher about performing these studies, these 3 studies, and we'll see how soon we can publicize the results. The fourth study is one that I've been talking with a pulmonology / sleep medicine expert about performing. This would be the clinical determination of the effectiveness of screening for sleep apnea by primary care practitioners using ultrasonic detection of internal deposits of monosodium urate crystals which form quickly but dissolve very slowly. The fact that they dissolve so slowly is that they're always around to be observed whenever it's convenient. They don't have to be They don't have to be sensed at just the right moment. So this is a fourth study that I'm looking forward to developing results from. The benefit of this approach is that because almost everyone with sleep apnea precipitates monosodium urate crystals, this would be a screening method for almost everyone with sleep apnea, not just for the small percentage of those who actually develop gout because they're genetically so predisposed. Here are some more questions and answers which you may be able and interested in looking at. I'm not going to take the time now to go through them. You can do it at your own leisure if you would like to. So, the next topic in this chapter is the importance of the gout sleep apnea connection. Why is this so important? It's important because gout is likely an early warning of sleep apnea, which when heeded allows for sleep apnea's early diagnosis and treatment, and which may also cure gout as well. If left untreated, sleep apnea has many serious, often life-threatening later consequences. What are those consequences? Well, there are two ways of looking at it, and I'll show you both ways. One is to look at individual diseases to see which of those have been reported to be consequences of sleep apnea. And there are many. The other is by reviewing a very large database of patients who've been diagnosed with obstructive sleep apnea and see what are the usual comorbidities of those in that sleep apnea database and compare that to the prevalence in the general population. So here's a chart that shows the first approach. This is a chart of all the consequences of obstructive sleep apnea that I could find written about in medical journal literature. And in fact, an earlier version of this chart I published in a journal called Medical Research Archives. Since I published it, as I continued reading, I found that there were reasons to revise and update the chart. Here are all the dates when I did that. What you're seeing here is my most up-to-date version of this chart. Now, when I was making up the chart, it seemed like it would be helpful if I listed these consequences of obstructive sleep apnea in three categories. First, those that usually are reversible, at least partially, just by resolving the obstructive sleep apnea. The third column is those that are usually irreversible. Even if the sleep apnea has been resolved, it's too late. And then the center column is those whose reversibility has not yet been determined. Now, in those consequences that are usually reversible, I thought it would be convenient if I could put on the chart the amount of time it takes for the reversibility to be noted. Immediately for gout attacks, up to 6 months for other things, some 3 months, 4 months. And there are a number of these reversible conditions where I did not have information about the time it takes, so there's none listed on the chart. Now you'll notice that many of these diseases, comorbidity consequences of obstructive sleep apnea, are life-threatening conditions. Sleep apnea can lead to death, almost always by one of these other life-threatening conditions. Here's the other approach. This approach is based on a publication by Huang and his colleagues in which they took a large database of people who had been diagnosed with obstructive sleep apnea and determined what are the consequences of sleep apnea that have a prevalence in that database of at least 1%. The database that they extracted this from was from a health database in New South Wales, Australia. In New South Wales, the law is that anybody admitted to hospital must have their complete medical histories inserted into a statewide database, the state being New South Wales. These are the conditions that, oh, by the way, that database has over 60,000 people with obstructive sleep apnea. And these are the comorbidity conditions that they found. I'm using the same nomenclature that they listed in their paper. This is the prevalence that they found with obstructive sleep apnea, as shown in their paper. One might think that, look, hypertension seems to be the most prevalent. Maybe that's a really good indicator of obstructive sleep apnea. And I don't think that that reasoning is sound. Let me give you an extreme example. Some astute observer may say, oh, look, everybody we see with sleep apnea has 2 ears. Why don't we use 2 ears as an indicator of, or as a screening method for sleep apnea? And the answer is because almost everybody in the general population has 2 ears. That doesn't show you, distinguish anybody with obstructive sleep apnea. The point being that what matters is not just how prevalent a condition is in the sleep apnea population, but its prevalence in the sleep apnea population relative to that in the general population. So I wrote in an article in Chest, I compared these results with the prevalence in the general population. Now, I could not find the prevalence of all these diseases in the general population in Australia. So I could find it for the United States, and I used the prevalence in the United States with the assumption that prevalence of these conditions in the United States would be quite similar to that in Australia. There's one condition where that is a bad assumption, and that condition is obesity, because at the time, obesity was about 2 times as prevalent in the United States as it was in Australia. I left the United States number here, and when I take the ratio, this is the ratio that I get. But if I had used the Australian number, the ratio would be 0.88. Now, these ratios I have listed in a hierarchical form, highest number to lowest number. And to me, the larger the number, that's the greatest indicator, that's the strength of the indicator of this comorbidity for sleep apnea. The strongest indicator is atrial fibrillation. Atrial fibrillation is a particular type of heart arrhythmia. And this number of 5 to 1 in the obstructive sleep apnea population relative to that in the general population is quite similar to what other researchers have found. So I'm pretty confident in that number. The second is gout. The close third is congestive heart failure. Now, there have been several papers showing that congestive heart failure also occurs in people with central sleep apnea as well as obstructive sleep apnea. Next is diabetes, and fifth is chronic ischemic heart disease, hypertension, and so on. There's one other thing in the paper by Huang. They made graphs showing the prevalence of each of these particular conditions as a function of age when first diagnosed. So they did this for the whole group of people with obstructive sleep apnea, and then for those who have obstructive sleep apnea, along with heart failure, along with diabetes, along with heart disease, along with hypertension. All four of those are life-threatening conditions. All these curves are bell-shaped curves, sort of distorted bells in some cases, but they all have a single peak. So when I looked at the age at which the peak occurs in those with obstructive sleep apnea, as compared to those in the obstructive sleep apnea population with diabetes, with chronic ischemic heart failure, with hypertension, and with congestive heart failure, I found that there is a shift in age of 5 to 15 years. These life-threatening consequences of untreated sleep apnea generally develop over a long time, whereas the precipitation of monosodium urate and gout, when it occurs, are likely to occur much earlier in the development of sleep apnea than that, so they are likely an early warning of sleep apnea. One other point to make about sleep apnea is mortality. There have been 2 long-term studies. Both have shown a very significant increase in all-cause mortality, that is mortality for any reason, with moderate or severe untreated sleep apnea. The lead author of one of those studies, Dr. Nathaniel Marshall, was interviewed for an article that appeared in Family Practice News, which is a newsletter for family practice physicians. He's quoted in that article as saying, sleep apnea has about the same effect on mortality as getting 18 years older. Now, in order to illustrate that point, I took a mortality curve, this one happened, and drew it in dark blue here. This one happens to be for the United States during the year 2005. And I redrew that curve in red, shifted over by 18 years, and then we can see what the implications are of Dr. Marshall's comments. Here's a particular example. At age 85, in the general population, there was a death rate of about 10,000 out of 100,000 people. That's 10%. In the sleep apnea population, that would occur not at age 85, but at age 67. And if we look at age 67, where in the sleep apnea population, there's a 10% death rate, in the general population, there would be a 2% death rate at age 67. That's a 5-to-1 difference. Back to me. Here's my experience with gout and sleep apnea. My personal medical chronicle. I first developed gouty arthritis around 1988. Around 1990, it was determined that my mitral valve prolapse was deteriorating. There was regurgitation, notable regurgitation through the valve. Mitral valve is a valve in the heart. Mitral valve prolapse is a congenital condition. In most cases, it's considered to be benign. In some cases, about 14% of them, medical intervention is recommended because its performance is deteriorating. In my case, I had surgical repair for it in 1999. I do not know if mitral valve prolapse, the deterioration of the mitral valve prolapse, results from obstructive sleep apnea. I'm going to let the cardiologists figure that one out. In 1996, I developed atrial fibrillation, which is a type of heart arrhythmia, and it was treated with a beta blocker. That treatment was effective, but not totally effective. There were still episodes where I could sense the presence of atrial fibrillation. In 1998, I developed diabetes, and it was treated with a sulfonylurea. The diabetes still remains with me, and here's some discussion of the changes in my treatments since that time. In 2003, I had a seminal event, a transient ischemic attack, which is a mini stroke. It put me into the hospital. It was determined to be secondary to the atrial fibrillation. And in order to try to prevent recurrence of that or something even more serious due to blood clotting, it was treated with warfarin, which was the blood thinner in use at the time. Further investigation while I was being treated for this was that led to my diagnosis of obstructive sleep apnea and the positional therapy resolution that I developed following the TIA. Once I did that, I realized that my frequent gout flares, that was frequent up to the time, had ceased immediately after overcoming the obstructive sleep apnea. Another thing which was sufficiently reduced within 6 months of overcoming the obstructive sleep apnea was the hypercoagulability. That is the propensity of the blood to clot. After that 6-month period, the warfarin was stopped. Now, the reason I know that the hypercoagulability was continually reducing during that 6-month period is that I had to have my blood tested frequently to determine the dosage of warfarin that should be used. And the dosage continually dropped through that period, starting at 5 milligrams a day at the beginning of that 6 months, ending at 3 milligrams a day at the end of it. The other thing that ceased permanently 6 months after overcoming the sleep apnea was my atrial fibrillation. Now, and once that ceased permanently, the beta blocker was stopped. Now, I know that many cases of atrial fibrillation have not ceased permanently after overcoming obstructive sleep apnea. In my case, it did, and in other cases too. So here is a photograph of me lying in my no gout sleep position, which is also my no sleep apnea sleep position. I've shown on this photograph an apparatus that I developed to train myself to always sleep on my side. The apparatus comprises an elastic belt strapped around my chest with 2 wiffle balls in the back straddling my spine. And the idea is, if I ever were to inadvertently roll over onto my back during sleep, that the discomfort of those balls would wake me, and then I would just flip back onto my side again. For those of you who may not know what a wiffle ball is, it's really a child's toy, and it's a spherical shell about the size of a softball made of hard plastic. Half of the shell has slots built into it, which makes it easy to slip the belt through, and the other half has no slots. The hard plastic on these shells is very incompressible. They're not like Nerf balls at all. Now, I used this apparatus for about 18 months, after which I determined I was trained. But in order to make sure I don't break my training, I sleep with my upper arm and my upper leg stretched out in front of me. They act as outriggers to help prevent me from rolling over onto my back. They operate like the outriggers on the ocean-going canoes used by Pacific Islanders. They prevent the canoe from tipping over. Likewise, my arm and leg outriggers prevent me from inadvertently tipping over. The other thing I do is I fold over my pillow so that my head is elevated and my neck is approximately level. I sleep with my mouth open, so I breathe through both my nose and my mouth for better airflow. Now, this position is probably beneficial for almost everyone who has obstructive sleep apnea, but it solves the whole problem only in a small percentage of those who have obstructive sleep apnea. I happen to be fortunate enough to be within that percentage. Okay, so here are takeaway messages. Most gout flares start during sleep. They are the direct result of sleep apnea's hypoxemia. Obstructive sleep apnea is very common, but it's woefully underdiagnosed. So, most patients who have sleep apnea don't know they have it, and their doctors don't know either. Obstructive sleep apnea has been associated with almost every non-infectious scourge disease of modern life, accompanied by significantly increased mortality. Gout is likely an early alarm signal for obstructive sleep apnea, allowing for treatment of obstructive sleep apnea before its irreversible life-threatening consequences develop. So, one of the first things that should be done when symptomatic gout first manifests is sleep apnea diagnostic testing, followed by sleep apnea treatment when warranted. My primary care physician has been doing that with all his gout patients for several years. He has found that a large majority of them were diagnosed with sleep apnea, even in a few cases when he would never have suspected it otherwise. And now my podiatrist has begun doing the same thing. Next point, overcoming sleep apnea is an effective treatment for gout in as yet an undetermined percentage of gout sufferers. Finally, the gout connection may lead to the development of ultrasonic detection of monosodium urate as a biomarker for sleep apnea, useful in primary care screening to lead to sleep apnea treatment before one of its irreversible life-threatening consequences develops, maybe even before gout symptoms first manifest. Now, at the bottom of this slide, I've put in here 2 complete references of medical journal articles that I've written on these subjects. If you want to see what else I've written, you can do a search on Google or PubMed. You can use the search terms apnea, gout, Abrams, B. Now, here are takeaway messages for gout patients. Get tested for sleep apnea. You will probably need a referral from your primary care physician for the testing to be done. If your primary care physician is resistant or reluctant, insist on it. It's too important. If you are diagnosed with sleep apnea, follow strictly the recommended procedure to overcome it. Because overcoming sleep apnea early enough will greatly reduce your risk for later development of its life-threatening consequences, thereby extending the life and quality of your life. Oh, by the way, overcoming sleep apnea may also cure your gout, as it did for me and for others that I am aware of. Thank you for your attention.